Education and Labor and Pensions Subcommittee on Primary Health and Retirement Security will come to order. Thank you all for joining us today for the hearing, Feeding a Healthier America. Current efforts and potential opportunities for food is medicine. Thank you to Ranking Member Marshall for partnering to bring together this very distinguished hearing. In 1941, President Franklin Delano Roosevelt convened his first White House conference on nutrition. At that conference, he stated that the food an individual eats fundamentally affects his strength, stamina, nervous condition, morale, and mental functioning. And today we would say the benefits flow to all in our society. Food security played an essential role in the reforms of the New Deal and the Great Society. As we moved towards a more equitable and just society, access to food was and is essential. In 1946, Congress passed the National School Lunch Act to safeguard the health and well-being of our nation's children. In 1964, Congress created food stamps, now called SNAP, or the Supplemental Nutrition Assistance Program, to support improved levels of nutrition for low-income households. And in 1965, Congress passed the Older Americans Act, which would later include and support nutrition programs for seniors. Food programs were core to the New Deal and Great Society because basic food security as a source of nutrition, health, and basic necessity is a key component of building a more just society. And at each point in history, it is the fight for a healthier, more just society that played an integral role in improving access to nutritious, healthy foods. In the late 1960s, in Mound Bayou, Dr. Jack Geiger wrote prescriptions for malnourished children to get food from black-owned grocery stores in Mississippi, and were paid for by the clinic's pharmacy. When the federal government pushed back on this, he said, the last time I checked, my medical textbook, the specific therapy for malnutrition was, in fact, food. Civil rights leaders demanded an end to hunger as part of the Poor People's March on Washington in 1968. And in the late 1980s and early 1990s, in response to the HIV/AIDS epidemic, programs like community servings, represented here today, and others developed food as medicine programs to make sure that people living and dying from HIV/AIDS receive care and support even when many were disowned by their own families. As David Waters said, community servings showed up for them and said, you're not alone, you're not alone, we're here for you. And we've made this beautiful meal for you. Food is medicine, an outgrowth of this movement for greater food security and healthier communities is a basic concept. It is the concept that the food that we eat impacts our overall health and well-being. And today we see food is medicine in medically tailored meal programs that address an individual's medical diagnosis. Symptoms, allergies, or medications. Produced prescription programs are allowing people to get financial support to buy produce to treat a health condition or risk. These programs are being integrated across hospitals and community health centers. Lowell Health Center in Massachusetts partners with Mill City Groves to ensure patients with chronic conditions can access healthy, locally sourced produce. East Boston Health Center is serving home by Blue One with diet-related diseases and for people with limitations on activities of daily living. We could save $13 billion in the first year alone. By comparison, Ozempic costs about $1,000 a month. Medicare spending for Ozempic, Rybelsus, Parmigiano reached 5.7 billion in 2022, up from 57 million. Cost savings promised by Food as Medicine. We need to feed programs by funding research and supporting community organizations like our local health centers and nonprofits who are running and developing these programs. And we need to make sure that there is no separation between our food systems and our health systems. Health providers must know they can prescribe food as medicine that their patients can access easily and affordably. But food as medicine is more than just cost savings. Food as medicine is a stop in the continuum of food justice to guarantee that from the farms to dinner tables, people can get the food they need to sustain themselves and their communities. What our planet can produce is as essential to our health as what our health systems can provide. With food as medicine, we can nourish a healthier America. So thank you, all of our witnesses. And now I will turn to recognize the ranking member of the Primary Health Subcommittee, Senator Marshall.
Well, thank you, Chairman Markey, for convening this hearing on food as health. A special welcome to our panel. And we have rescheduled this one, so thanks for turning your schedules again around to come back and help us out understand this issue out a little bit more. And I want to say a special thanks to the majority staff for all your help putting this together as well. Well, I'm often asked, most days I get asked, what can we do to drive the cost of health care down? What can we do to save Medicare? What can we do to impact maternal morbidity? What can we do to impact the diabetes epidemic that we're seeing, ADHD, cancer incidents, all those? What can we do to impact all of those? And I would make the case that sound nutrition is not just part of the answer, it is the answer to those dilemmas. Food isn't just medicine, food is health. And I look forward to the testimonies today. I think the challenge before us is how do we turn these ideas, these concepts, the research you've all done, how do we turn it into practical programs, policy from the federal government, but also how can we put wind beneath your wings as you all try to solve this problem at the local level. So welcome everybody, and we look forward to your testimony.
Thank you, Senator Marshall, very much. And now we're going to turn to our witnesses. Our first witness is Ms. Jean Teranova. So thank you for being here today. Ms. Teranova is the Senior Director of Policy and Research at Community Servings in Boston, an organization which provides medically tailored meals to individuals and families facing chronic illness or food insecurity. She currently serves as a principal investigator for 2 NIH studies examining the impact of community servings meals on health outcomes and quality of life for individuals with diabetes and food insecurity. And she also serves on the policy committee of the Food as Medicine Coalition and as a board member for the Aspen Institute's Food as Medicine initiative. So, Ms. Teranova, thank you so much for being here. Whenever you feel comfortable, please begin.
Thank you so much. Chairman Markey, Ranking Member Marshall, and members of the subcommittee, thank you for the opportunity to testify in this hearing. My name is Jean Teranova. I'm Senior Director of Policy and Research for Community Servings. Our organization was founded in Boston in 1990 by a diverse coalition of activists, faith groups, and community organizations to provide home-delivered meals to individuals living with HIV and AIDS at the height of the crisis. We were founded based on a simple principle, although perhaps revolutionary at the time, that food is medicine and that we can drastically improve health simply by changing an individual's diet. In the last 34 years, Community Servings has grown from a neighborhood to a regional program serving medically tailored meals, MTMs, to thousands of people across Massachusetts and our neighboring states. We've grown to serve diverse populations experiencing critical illnesses like diabetes, cancer, and many others. Over our history, we've delivered over 13 million meals, including 1.1 million last year. And with our nationwide partners in the Food is Medicine Coalition, we've learned that nutrition plays a crucial role in the healthcare space. I want to thank the subcommittee for shining a light on this important issue. Since the 2022 White House Conference on Hunger, Nutrition, and Health, healthcare stakeholders have been paying closer attention to nutrition, and specifically how nutrition can better be integrated into healthcare delivery. We have great experience with this in Massachusetts. Since 2020, our Medicaid program has provided reimbursement for nutrition services through an innovative model funded under an 1115 waiver. Community Servings now maintains contracts with 12 of the 17 accountable care organizations participating in this program. We've been able to achieve this integration because our programs have been rigorously studied, including in a peer-reviewed 2019 study published in JAMA, which I've submitted with my written testimony. That study found, among other benefits, that MTMs helped achieve a 16% net savings on total healthcare spending due to decreased emergency room visits, hospital admissions, and emergency transportation services. And the net savings factors in the cost of the meals. The Aspen Institute has just released its updated Food is Medicine Action Plan, showing that there are many other studies demonstrating that MTMs can significantly reduce healthcare utilization and costs. Medically tailored meals are a simple concept, but are complicated to implement. At Community Servings, our nutritionists evaluate each client individually for their health and dietary needs, their community access to food, and their ability to provide for themselves. The client is then assigned one or a combination of Community Servings 16 meal plans to meet their food preferences and dietary requirements. We provide a week's worth of meals at a time, often for both the client and their family. In addition to the meals, the weekly delivery includes snacks of fresh fruit and yogurt and a quart of milk. We also provide nutritional education and counseling to those we serve so that they have the tools to continue on a healthy path once they've moved on. And the results are powerful. Chuck, a 66-year-old with diabetes and vascular issues, has lost over 50 pounds and avoided a foot amputation since receiving a cardiac diabetic diet from Community Servings. And Janet, a 60-year-old with an autoimmune disease and cancer, credits Community Servings with taking an intimidating burden off her plate by providing her with medically tailored foods and allowing her to focus entirely on her other health needs. Our impact goes beyond the patients we serve. Food is Medicine programs also benefit local food supply chains. Our local foods program intentionally sources as much food as we can from local providers, totaling over 50,000 pounds of local fish, fruit, and vegetables every year. We have made great strides in increasing access to integrated food with medicine, but more still can be done. Congress should increase research funding through the National Institutes of Health to explore the benefits of MTMs and should seek other avenues to integrate nutritional interventions into programs like Medicare. We thank Chairman Markey and Ranking Member Marshall for their brand new trio of bills that would task federal agencies with publishing nutrition best practices and to increase access to MTMs through community health centers. We also strongly support the bipartisan, bicameral MTM pilot bill led by Senator Booker and Ranking Member Marshall. We need to be increasing such connections between the healthcare system and the food system. Again, I thank the subcommittee for the opportunity to testify today and welcome any questions you may have.
Thank you so much, Ms. Teranova. Next, we're going to hear from Erin Martin, who is a gerontologist and serves as founder and director of Fresh RX, a produce prescription program which collaborates with primary care clinics and local farmers to provide free, nutritious produce to people living with diabetes. Ms. Martin serves as president of the Urban Ag Coalition and co-leads the Oklahoma Food is Medicine Policy Coalition. So we welcome you, Ms. Martin. Whenever you feel ready, please begin.
Chairman Markey, Ranking Member Marshall, members of the Help Committee, thank you for this opportunity to discuss the transformative power of the Fresh RX Oklahoma program. My name is Erin Martin. I'm a gerontologist, the director of FreshRx Oklahoma, the co-lead of Oklahoma's Food is Medicine Policy Coalition, and a proud member of the National Produce Prescription Collaborative. I started working in long-term care when I was 15 years old. Since then, I have worked in all levels of long-term care, including HUD housing for 62 and older, where I saw people on 15 to 32 prescription drugs per year. During that time, I attended the first and leading school of gerontology in the world at the University of Southern California. And in Italy with USC, I studied death and dying and began to study the blue zones, where people die of something called old age on 0 prescription drugs. I started to understand deeply the connection of food and health. When the pandemic hit, a physician from North Tulsa shared that his diabetic patients were compliant in their medications and their doctor's visits, but that their health was still declining. To try to address this, we co-founded FreshRx Oklahoma, a produce prescription program that launched in North Tulsa, a community with an 8.5-year, sometimes longer lifespan difference from South Tulsans, a community without a grocery store for 14 years, and a community with the highest mortality rates of diabetes in our county. Our program empowers individuals with type 2 diabetes by providing them with biweekly, locally grown produce for 12 months, along with 4 to 6 cooking and nutrition classes per month, and quarterly health metric checkpoints. Participants, or members as we call them, are either self-referred or referred from healthcare professionals at one of our 22 partnering primary care clinics. This also includes federally qualified health centers, PACE clinics, and clinics even serving the uninsured. Provider partners utilize a prescription form to refer the patient and verify their diagnosis. From there, we enroll the member, and they begin the program at the very next food distribution cycle, where they receive a starter kit complete with cooking utensils, cookbooks, and more. This program has significantly shown success in reducing A1C levels and weight, enhancing both quality of life and reducing medical costs. With our first 300 patients, 80% have shown a reduction in their A1C level with an average reduction of 2.2 points. Our largest reduction we've seen went from a 13.6 to a 5.4 in less than 6 months. And our record weight loss was just hit at 116 pounds, fully reversing her type 2 diabetes and coming off of all of her medications. Many of our members report having had diabetes for over a decade, but experiencing improvements in just a matter of weeks in our program. I'm extremely proud of what FreshRx has accomplished, but I'm also proud of my colleagues across the country who are leading other successful produce prescription efforts. There's many ways to provide these services, including prepaid debit cards that can be used in retail, farmers market vouchers, and even online shopping models that work well for different communities. Programs must reflect the communities for which they serve, providing food that is culturally relevant and supporting dignity of choice. Our specific model supports local agriculture, stimulates local economies, and most importantly, transforms lives through improved health. I'm pleased to share that since its beginning, FreshRx has expanded into beyond North Tulsa to 5 rural cities with the Muskogee Creek Nation to serve their diabetic and pre-diabetic populations. Implementing food as medicine is a smart economic decision with an enormous return on investment. Our program's success is a testament to the power of integrating a food as medicine approach with our healthcare framework and providing a regenerative, cost-effective solution to our nation's health crisis. The Senate Health Committee has an opportunity to integrate produce prescriptions across federal health programs. Doing so offers a promising pathway to not only manage and prevent chronic disease, but to save on healthcare spending and resurrect local economies. Again, thank you for considering the potential of food as medicine. I'm eager to answer any questions and discuss how we can expand these vital services to enhance health outcomes across our country.
Okay. Well, Mr. Chairman, next I want to introduce Dr. Dariush Mozaffarian, who's the director of the Food as Medicine Institute at Tufts University, located in Boston, Massachusetts. Dr. Mozaffarian is a cardiologist, a scientist, and globally recognized expert in nutrition, medicine, and public health. I've had the opportunity to work collaboratively with him since being a freshman in the House of Representatives, where we co-founded the Food as Medicine Working Program. As one of the leading experts on food as medicine, Dari was invited here today to share the vast contribution he's made in making food as medicine something we can apply successfully across our health system. Dari is also proof of the American dream. He's the child of immigrants. He couldn't get into Kansas State, so he went to Stanford University to get his bachelor's degree, an MD at Columbia University, and a doctorate in public health at Harvard University. Thank you for agreeing to testify and sharing your expertise with us. Dr. Mozaffarian.
Well, Chairman Markey, Ranking Member Marshall, and distinguished committee members, thank you for the opportunity to share what I've learned and what I've seen from Americans across our great nation. As a heart doctor, I see firsthand people of all ages and backgrounds suffering from diet-related diseases. As a public health expert, I see the incredible challenges Americans face every day to obtain and eat nourishing food. And as a researcher, I study the science on how foods affect health, and I study the effect of policy changes to achieve well-being and health equity. Over the course of any given year, I see and speak with thousands of people, thousands of Americans, who know in their gut that our food is making them sick, and yet feel helpless to do anything about it. This inability to eat well is literally lethal. Poor nutrition is the top cause of death and disability in the United States. I should drop the mic there. Causing more harms than tobacco use, alcohol, opioids, physical inactivity, and air pollution. Each week, the food we eat is estimated to kill 10,000 Americans, cause 1,500 new cases of cancer, and cause 16,000 new cases of diabetes each week. These likely underestimate the full harms, given what we're now learning about the effects of our food on the gut microbiome, the brain, depression and mental health, child development, autoimmune diseases, immune function, and more. This is also driving societal discord. Each year, 40 million Americans, 1 in 8 households, experience food insecurity, which is linked to worse nutrition, more diet-related disease, and greater healthcare spending. Americans with lower incomes in rural communities and from marginalized racial and ethnic groups are at highest risk. Our food is also an urgent matter of national security. 8 in 10 young Americans don't qualify for the military, and the leading medical disqualifier is overweight and obesity. Poor nutrition is crushing our economy, causing $1.1 trillion in economic losses every year from preventable healthcare spending and lost productivity. For diabetes alone, the U.S. government alone spends nearly $200 billion each year on direct medical costs for a disease that is almost entirely preventable and treatable with better food. As detailed in my written testimony, the economic costs of diet-related diseases are also crushing U.S. families, U.S. businesses, the federal budget, and the national debt. The lack of attention to these harms of our food explains so much about the problems our country faces today. Tens of millions of sick Americans, hundreds of billions of dollars in preventable healthcare costs, suffering U.S. businesses, exhausted state and federal budgets, and frankly, exhausted policymakers fighting over the shrinking remainder. Senators, if you want to do the things that you believe are important for the American people, you will never have the resources you need until we reduce healthcare spending. And this will not happen until we fix food. The nation's state of diet-related disease is not okay. It's not normal, and we can fix it. Nutrition is the top cause of poor health, and yet historically has been ignored by the healthcare system. This is finally changing with food as medicine interventions. My written testimony describes the various types of food as medicine therapies. You've heard from the preceding witnesses on these, their efficacy, and their cost equivalence or even cost savings compared to traditional medical treatments. As shown in many states and in private healthcare demonstration projects around the country, food as medicine can improve health and save money. There's almost nothing in healthcare that can do both of those things. Food as medicine programs can also support local farmers and regional food systems, serving as an economic engine for rural communities. With the current evidence in progress, the nation is at a tipping point to potentially accelerate food as medicine. Action is needed. Today, the vast majority of Americans cannot access these therapies, and more research and implementation are critical to assess which programs work best for which patients. My written testimony summarizes potential congressional actions in this area. For example, advancing food as medicine at community health centers, serving the most vulnerable Americans who will benefit, such as through S-2840, introduced by Senators Sanders and Marshall. Advancing food as medicine in Medicare, such as through S-2133, introduced by Senators Marshall, Cassidy, Booker, and Stabenow. Integrating food as medicine into the Older Americans Act, including produce prescriptions and medically tailored meals. Providing meaningful funding to NIH to launch Food as Medicine Centers of Excellence, a concept which has already received NIH clearance and is ready to go. And even utilizing report language to encourage food as medicine in Medicaid 1115 waivers, food as medicine pilots at CMMI, food and nutrition security screening and care referrals in the electronic medical record, and meaningful nutrition education for doctors, speaking to the national accreditation and licensing organizations that oversee U.S. medical education. Healthcare systems, payers, doctors, patients, public and private vendors, food retailers, pharmacies, advocacy and clinical groups, and even from our national polling, the American people all support food as medicine. It's time for congressional action to help bring food as medicine to the American people. Thank you for the opportunity to testify.
Thank you, Dr. Mozaffarian. Next, Mr. Chairman, I'd like to introduce James Carter Williams, the CEO and Managing Principal of iSelect Fund, a venture capital firm that invests in technology that bridges the gap between food health and ag tech. Mr. Williams has an extraordinary career, problem-solving complex systems. An engineer by training, had a long stint in developing innovative cost-saving solutions for Boeing's technology planning process that brought the F-18 in under budget. He successfully invested in early-stage ventures and corporate research. He's now working to problem-solve a more complex system, healthcare, with a unique mission centered on food as health. Our goal is to learn about the intersection of innovation and investment that will help combat the obesity and diabetic epidemic. He has an MBA from MIT Sloan School of Management and a BS in Mechanical Engineering from Rensselaer Polytechnic Institute. Thank you, Carter, for being here, and the floor is yours.
Thank you, Chairman Markey, Mr. Ranking Member Marshall, and distinguished members. It's my pleasure to appear before you today to reflect on the innovations reducing the healthcare cost of poor nutrition. My name is Carter Williams. I'm an engineer with a degree from Rensselaer and MIT. Over the last 35 years, I've focused on innovation in complex systems, spanning aerospace, energy, agriculture, and health. I served in senior roles in Boeing's Phantom Works and several successful startups. Since 2014, I have led iSelect, a venture fund focused on the theme Food is Health, investing in more than 70 ag tech and health tech startups. Over those 10 years, we have also met with more than 5,000 entrepreneurs, and this is what we have learned. The U.S. spends $1.7 trillion on food and $1.9 trillion on the healthcare cost of poor nutrition. Type 2 diabetes kills 283 Americans every day. Goldman Sachs has concluded that the U.S. GDP would grow 1% annually if we cured obesity. In 2000, the U.S. sequenced the human genome, launching companies with breakthroughs in immunotherapy and vaccines, reshaping treatments in healthcare. But we still have a problem that can be solved with similar thinking. For 350,000 years, humans were thin. In the last 50 years, we're fat and diabetic. Innovation is stepping in. In the near future, grocery stores will offer seamless access to a nutritional coaching to get you better food through medically tailored meals or natural low-cost forms of Ozempic. You eat what you enjoy, and what you enjoy is better and affordable. Your calorie intake is 25% less than your parents', 45% less from processed food. You lose weight and gain muscle mass. Regenerative vegetables, frozen or fresh, are tasty, nutrient-dense, and affordable. Beef, managed on grasslands with virtual fences, are net carbon positive, deliver balanced omega-3s and 6s, in reducing clogged arteries. Processed foods are sweet and tasty, but zero diabetic impact, made with healthy sugars from agricultural waste. Prebiotics fuel your gut microbiome. You sleep better and you have less depression. Medical care is now functional medicine, forestalling disease, easily accessed. Health data is part of the grocery store mobile apps. The app knows your genome, your blood work, your blood pressure, and the food you purchase. Integrated into your health insurance, reminding you of quality choices. Everyone gets the standard of care. Comorbidities are a distant memory. Your health data is protected by the blockchain, anonymized, integrated into synthetic control arm models, comparing your genetics and health to peer groups, improving the work at FDA. Inspired by the original Human Genome Project, innovation is driven by the Human Microbiome Project, the Human Nutrition Project, the Soil Microbiome Project, all working to improve the quality of the data we use for our science. Not all crops are healthy. Their nutrients vary. In-field spectroscopy reveal the array of nutrients in meat, fish, vegetables, and grains, a form of nutritional quality control, empowering farmers, ranchers, CPGs, and processors to optimize nutrient density and cost. Product labels are accurate and complete. Startups use AI to scan every journal and historical artifact to find natural solutions that improve health, testing thousands of natural products against digital twin of human nutrition in billions of configurations and speeding the development of new technology, replacing an array of pharmaceuticals with quality nutrients. Farmers have transitioned to biologics that rebuild the soil microbiome, improving crop nutrient intake. Crops are robust against disease, drought, and weeds. UAVs use precision sprayers and lasers to reduce chemicals, improving farmer profits, increasing yield, and safer food. These technologies are all real. They all exist today. Some are controversial, some more affordable, but more than enough to reduce the healthcare costs of poor nutrition. American entrepreneurs in agriculture, food, and health, working with FDA, USDA, NIH, and other NGOs, can solve this problem, lowering cost, improving sustainability, increasing longevity, and driving GDP growth. Thank you.
Yep. Thank you very much. And now we'll turn to questions from the subcommittee. The Older American Act includes essential nutrition programs for older adults, including meals at congregate sites like senior centers or delivered to their homes. As a member of the working group to reauthorize this law, I remain committed to this sacred responsibility. Ms. Martin, can you elaborate on how food as medicine can be incorporated into the Older Americans Act?
Yes, thank you. I think that these federally qualified health centers, rural health centers, and other congregate meal programs would be drastically enhanced and produce incredible health outcomes by being integrated in those systems.
Okay. And can you discuss how pilot projects in the Older Americans Act could demonstrate the benefits of integrating medically tailored meals or prescription food programs for older Americans?
Yes, and we see most of the people we serve actually are over 50 and experiencing these outcomes consistently. There is a federally qualified health center that has a diabetic program. They offer some food bank boxes, but we also get referrals because we really enhance that program from that federally qualified health center. So we believe that having it more integrated in that system would be way more beneficial for the older Americans.
And this is such a great bipartisan issue. You're not often going to have the Democratic witness from Oklahoma and the Republican witness from Massachusetts. Okay, wow. So the recombinant political DNA here shows that many things are possible. So, Ms. Teranova, you have served as the principal investigator for two large-scale NIH studies examining the impacts of community servings meals on health outcomes. Why is investment in NIH for research like this so important?
Thank you, Senator. It's really critical.
Could you turn on your microphone, please?
Thank you. It's really critical because policy leaders are feeling that there is a gap in research, and in particularly in communities such as rural communities. Community servings, as you know, has published 5 peer-reviewed journal articles on the impacts of medically tailored meals on health outcomes and healthcare costs. And there have been other studies that were also cited in the Aspen Institute's recently updated report on food as medicine. But there still do exist gaps, and in particular in multi-site settings, in rural settings, and for specific populations. And so investing in research for NIH is really critical to addressing these gaps.
Okay, so Dr. Mozaffarian, what further research, in your opinion, needs to be done on this subject?
Yeah, I think there's a lot of questions, like anything in medicine, right? We know enough to get going and do things now, but we also need more research. I really like the NIH concept of these food as medicine centers of excellence that's built on the cancer centers of excellence model. About, I think in the 1960s, the NIH launched these cancer centers of excellence. Maybe later, I'll have to check the date. But now almost every state has one, and these centers of excellence integrate patient care with research, with community outreach, and with education. I think having these hubs of knowledge generation in regions across the country would be really important. There's questions we need to ask. What's the right dose? Is it $50? Is it $100? How important is sharing with the family? If the family's bigger, how much more food do you have to give? What should the duration of the program be? Some people may need these programs for just a few weeks. Some people may need it for a few months. And like other things in medicine, some people may need it for their whole life, and we have to understand that. So I think those are all really critical questions that need to be answered with better research. That could be done by NIH, it could be done by USDA, it could be done directly through CMMI and Medicaid.
Dr. Mozaffarian, how do you think the cost savings in food is medicine programs relative to the growth of expensive medications like Ozempic that are used to treat diabetes and weight loss?
Yeah. One of the dirty secrets of healthcare is almost nothing saves money. If it did, we wouldn't have a $4.3 trillion healthcare system. And so blood pressure screening and control, cancer screening and control, cholesterol screening and control, none of those things save money. They cost money. We get a good buy for the dollars we spend, but they cost money. Food as medicine is exciting because for the right patients, particularly very sick patients who receive medically tailored meals or produce prescriptions, the research suggests we might actually save money net of the program. So I think that's really exciting. I don't think they'll save money in every case. I think there'll be other cases where it'll be a good buy, just like giving a generic cholesterol-lowering drug is a good buy. So we shouldn't expect cost savings in every case. But I do think this is a really exciting area. And compared to GLP-1s, which Senator Sanders produced a report this week out of the Health Committee that if half of Americans eligible for the drug went on the drug, we would double our national pharmacy spend on all prescription drugs combined. And so we just can't afford those drugs as effective as they are. And so we need to integrate nutrition and food as medicine and lifestyle together with GLP-1s to be able to mitigate that cost.
Okay, thank you. Senator Marshall.
I'll defer to Senator Braun.
Thank you, Mr. Chair and Ranking Member. I ran a company for 37 years prior to coming here, and I remember in 2008 how it got to a point where our health insurance premiums were going up to where we were lucky if it was only 5 to 10%. That was the line I'd get every year. It got to a point where I couldn't raise deductibles anymore, couldn't change underwriters any more often, had to look at. And the insurance companies basically told me, they said, we are a system of expensive remediation and we pay no attention to wellness and prevention. That sounded kind of philosophical, and then I dug into how that was going to work for me to lower costs and have healthier outcomes. Well, we did that all in one day. I took their advice, created healthcare consumers out of all my employees to where they watch what they eat. We give them every tool to do that. Have not had premium increases now in 16 years. And a lot of it is watching what you eat, because the foods that are the worst for you generally got the most calories in them. And then you got to work hard to shed the bare weight that you accumulate. And then you're not necessarily replacing it with good, wholesome foods. My question will start with Mr. Williams. I'd like each witness to give me your opinion. How did we get here? How much of it is a system of health care that they don't even give much study to nutrition? it is an expensive business of remediation. And then about our food supply production, which is more on processed foods as opposed to wholesome ones. I'd like to know who's more at fault when we really know that you should be eating better. Is it the healthcare industry that's not being voiceful enough, or is it big food processing that gives us generally many foods that just aren't nutritious for you?
It's a lot in there.
Yeah, there is.
I think from an economic standpoint, it's notable that at the end of World War II, we said we don't like famine, and we've got to boost calorie production, and we set down the path of the Green Revolution really to stop worldwide famine. American innovation drove the cost down of those calories. Those calories tended to be, for various reasons, cheap, low nutrition calories, and that sort of set this up. I think that same level of innovation with a different focus around nutrient density can change the food system itself so that when you go to the grocery store, those kind of calories have been moved around a little bit. There's a lot more in there, but the basic food is moving to nutrient dense, as Erin is working with. When she uses regenerative crops, people like them better, they taste better, and they lead to an improvement. So the technology's moving in that direction. I think a challenge for healthcare is over time, healthcare has been maybe more about healthcare, not about making people well. I think the movements by Dr. Hyman around areas like functional medicine in terms of getting it before you get sick are big shifts, and we're seeing that kind of new care delivery mechanism. It is unclear how to pay for it correctly, but when we take some of these solutions into the healthcare community, our entrepreneurs find it's very difficult to get them properly covered. You get into the morass of everything.
So I want to agree with what Carter said about how we got here, and I would add, the evidence, vitamin deficiency diseases were rampant in this country, in the 1920s and 1930s, diseases like pellagra and rickets and all these diseases. So in addition to the concern about getting enough calories for a booming world population, there was concern about vitamin deficiency diseases. So when you walk down the cereal aisle today and you see starchy, inexpensive calories from monocropped, crops fortified with vitamins, that was a conscious creation of meeting the two scientific goals of the 20th century. There were no villains in that original goal, right? This was a very positive goal, and we did it. We probably prevented 1 billion people from starving, and we essentially eliminated vitamin deficiency diseases in most countries in the world. But we created unintentionally this hyper-processed, very monocropped food culture that has made us metabolically sick. And so it's that same mix of what got us here in the 20th century we can now use to go to the next phase, which is to combine government policy with private sector innovation with the best science. And we can do all that together and move forward.
Before I run out of time, let's go down the line. Ms. Martin.
Thank you. I think it's definitely a combination of both. I think having local and fresh food is really important because when it's being shipped from long distances, it's prematurely picked and artificially ripened, and by the time it's in somebody's kitchen, it's very devoid of a lot of the nutrients. So having local food systems to support these food as medicine programs, I think, are vital. And then on the healthcare side, when we are enrolling these participants who, like I said, have had type 2 diabetes for a decade, we tell them that food, what all problems are you having? Oh, pain, depression, diabetes, all these other issues. Food could actually fix all that. And it's the first time that they're hearing about this. So a combination of both.
Thank you.
Thank you.
And Senator, I will just say, with respect to the medically tailored meal intervention, we have a dual focus that specifically address marginalized communities that for people who experience both food insecurity and diet-related illness. And so we're not talking about people who are in a job who can prevent their disease necessarily through food. We are talking about people who have cancer, HIV, diabetes, very critical illnesses, the 5% of people who are accounting for 50% of healthcare costs. And so we're really in the business, I suppose, at community servings and within the Food is Medicine Coalition of addressing these illnesses as a treatment as opposed to really a prevention.
Thank you so much. I'll note that when we started producing food that had a lot of vitamins and kind of empty calories, that's when the healthcare industry really started to shoot up, which is now the biggest industry in our country, nearing 20% of our GDP. Thank you.
Senator Smith, Senator from Minnesota.
Thank you so much, Senator Markey and Senator Marshall. Thanks to our panelists also for being here. This is super interesting. So you all are describing a healthcare system where costs are going up dramatically at the same time that poor health is increasing. And food, which is arguably has the biggest impact on good health and is the biggest cause of poor health, is sort of like knocking on the door of this system saying, let me in. Let me be, I can be a part of the solution here. I think it's also true, and this was, I think you were alluding to this a little bit, Dr. Mozaffarian, that, at the same time that this system is functioning so poorly, you have some big companies that are making a lot of money off of it. Insurance companies, big food companies that are making a ton of money off of selling unhealthy food. So I think that that bears understanding as we try to figure out what to do here. There's so much that we could talk about, the research side of it, the side about developing products and therapies, and then the kind of the utilization side, the adoption piece of it. How do you get these products and therapies adopted? And so I want to actually focus on that a little bit as we think about what we can do in Congress to support this. Maybe I'll start with Ms. Teranova and Ms. Martin. Could you talk a little bit, just like hone in on one thing? I think we know that we're getting better adoption when you have medically tailored meals compared to a specialized dietary plan. I think I read that. I'm not sure if that's true, but could you just tell us if there's anything we can learn from those two products or therapies about how we can increase utilization or adoption by patients or consumers?
I think, Senator, that it really gets to the question of what is a medically tailored meal and how are we defining it. And it's really important that there be uniformity and agreement around the standards and definitions. And the National Food is Medicine Coalition has just released an accreditation criteria and requirement that standardizes what is this intervention. And it was developed by a committee of registered dietitian nutritionists. And this is the model that has really been tested in the research that we've published. And so it's just very important that we all come to a consensus on what is a meal, how many meals a week, what
You're
is
all
the
talking the same
proportion.
language about
Exactly.
what it is that you are prescribing or what the therapy, I'm using the kind of medical terms here, the therapies. Ms. Martin,
Exactly.
how do you see the issue of getting improved adoption or utilization for, say, we've agreed on what the therapy should be?
From the studies that I've read and how we've enacted this program is that I think the best results come from programs that are a hybrid model and having both education and food. And we really curate the food offerings that we provide. And so I think having these very well-defined programs and accredited education that they're going through, like just delivering food, yes, has impact, but really empowering people to have the knowledge to continue those behavioral changes.
In my home state of Minnesota, we have many East African immigrants, we have many Latino people, we have many Hmong people, we have many Swedish people. Everybody's cultures and food are quite different. How do you consider people's cultural preferences and their culture broadly speaking as you think about what that food is that they're getting?
That's a great question. So the majority of people that we serve are from the Black community and Indigenous, and we ask them what they would like. And no farmers at that time were growing collard greens. And so we commissioned the farmers to grow collard greens, and now we have more collard greens than we know what to do with. And so we're asking the people, and we also hire people from the community that reflect those that we serve, and we're asking for that input. We give a survey that says, what food do you like? What do you not like? What kind of indigenous varieties of food? And we also look for growers that reflect that. So we have Hmong growers,
That
Black
gives you the
growers.
integrated system that you're
Absolutely.
looking for.
Yep, building a community.
Right, right. Mr. Williams, before I ever was a senator, I worked for General Mills, and I was a marketing person. And so as I'm thinking about you working on what you do from a venture capital perspective, a business perspective, how do you see this question of implementation, kind of utilization or uptake? I mean, in marketing language, you'd be talking about how you get trial.
Yeah. So when you're dealing with an entrepreneur, you're trying to get customers to adopt the product.
Right.
And the main thing here is everybody wants to be healthier. And you really have to build a product that's so much better in a sense that people adopt it despite the friction. In many ways, what Erin's doing, she is doing that in the community. Most of the patients that she deals with had no idea that they could feel better if they ate better. A very basic thing. So from a standpoint of the way we see it, I would say that it's the people who will compete against General Mills, introducing products that do meet the needs of consumers who want to be healthier, and that you're getting into that part of their psychology, and that they adopt it, and that General Mills follows in time. I will say that the Ozempic is driving processed food demand down by about 45% in certain patient populations. The cost of Ozempic is going down. So if that gets bigger, the General Mills of the world are going to be under a lot of challenge, and General Mills has been focused on sort of value engineering product to lower cost. They're going to start running into some challenges where they got to think differently about how they design the products. So they've got a lot of challenges on their face.
Thank you, Mr. Chair. I've gone over my time. Appreciate it very much.
Yep. Now we'll recognize, I'll just say that when I was a boy watching Superman, and all of a sudden, I'm told that if I can send 3 box tops from Frosted Flakes, this new product that they had, to Tony the Tiger, I would get a Superman t-shirt at home. And so we were moving from cornflakes and Cheerios and Pep to Frosted Flakes, and I got a Superman t-shirt. So they knew what they were doing in marketing, for sure. And that t-shirt, by the way, completely shrunk in the first washing. So I learned about consumer ripoffs immediately. Senator Hickenlooper from Colorado.
Great, thank you, Mr. Chair, and thank all of you for being here. I appreciate your time and all your effort here. Community health centers have consistently led the way in a lot of the efforts around this. Colorado has a group of community health centers called Peak Vista Community Health Center partner, and they partner with Care and Share Food Bank. They serve 29 counties in southern Colorado. It's almost half the size of the state. They've got a number of events where Care and Share will show up with a tractor trailer full of food, and they demolish it. These are things like back to school events or school physicals. Ms. Teranova, what role have you seen in terms of community health centers within Food is Medicine, and how can we implement a model like that outside of beyond community health centers?
Community health centers really do play a vital role in both innovation as well as in continuity of programs that exist. Community health centers are really key referral partners for our medically tailored home delivered meal programs. As you said, they can also offer pantry and programs right on site and are trusted advisors for the patients that they serve. So they can play really a critical role in maintaining and continuing these programs.
Right, and I think it is amazing. And so I am a lifetime lover of sweet things, I was in the brewery business, brew pub business for a long time. So I've learned the hard way that moderation is the choice here in a lot of these things, that genetically we, for various reasons, are inclined towards things that aren't necessarily good for us. I guess we have a company in Colorado called Virta that actually provides coaches. It uses technology, keeps records, monitors glucose and other easily traceable biologic indicators, allows people to really every day be conscious of what they're eating, and allows them to eat things in moderation, maybe not as much as they did before, but at least in some cases matches Ozempic. And without their supervision, I actually, I got to the point where I was pre-diabetic a year ago, and so I basically almost quit sugar completely, as close as I could come, and dramatically reduced my alcohol consumption. And I lost 10% of my body weight in the course of 7 months. I thought I was sick, and yet that shows how much excess is there. In terms of how do we get this more accessible, and I raised the question or the example of Virta just because they engage people. People are coached and they're they want to solve this issue for themselves. How do we get people to do something, assuming that we've got the resources, that isn't naturally their inclination? And obviously, the people that are very sick can resolve issues of pain and depression. I'm not worried about that. Those people that are going downhill, but consistently, but slowly. And I guess let's start down at the end with Mr. Williams and then Mr. Mozaffarian.
But I think things like Virta is, there are a lot of people in the medical community that don't even realize it works. So there is a bit of an education process of the medical community getting a better understanding that there are other interventions than putting somebody
Right, they
on
use no
function.
drugs. I mean,
Excuse me?
Virta uses no pharmaceuticals at all. It's all just food and rearranging when you eat food and what food you eat and some level of moderation.
Yeah, so it's a multifaceted challenge, but I think the one is the way doctors act. They need to learn more about these solutions. What we're saying here on the panel, there are doctors, I think, that really don't believe that these kind of solutions can step in. The second is you'll see the first wave of things like this. Then you'll get a bandwagon effect. The first one person started using a computer, nobody else used it. Then everybody else, it became more obvious. We haven't gotten to that bandwagon effect, and when we get to that bandwagon effect, we're going to start seeing simpler versions of it. So we're on that pathway to it. I don't know if I can give you a trick to it, other than to recognize the Virta system does not scale to 200 million people. Right. So we've got to move to that next level of better information and exposure to everybody else, that it's the art of the possible.
Right.
I'd add that, the way I look at it, Willie Sutton, the bank robber from the 30s, he was arrested, and they said, "Why do you rob banks?" He said, "That's where the money is." And so when I look at solutions to the food system, we've been driving towards cheaper calories, cheaper food. We need to flip that and reward farmers, producers, consumer packaged good companies, retailers that are selling healthier food through dollars that are already spending, particularly dollars in healthcare. And so I have a vision that the food is medicine movement, which is built into healthcare, also then starts to shift the incentives for how we produce food from the ground up, and really just creates a virtuous cycle instead of a negative, vicious cycle, so that ultimately Americans that aren't even in a food as medicine program, they have healthier choices at the grocery store. The cereals are better, the snack bars are better. We need processed and packaged food. We're not going to get rid of that, but we can make those healthier with better science and with investment. And so right now we're pouring money down into healthcare and taking money away from every other priority, including food. If we put some money into food, we can start to reverse that cycle and make food healthier for everyone.
Yeah, great. Ms. Martin?
I think the health coaching aspect is great. Like you really can get that referral from the doctor and then have someone handhold them through that process. And that's what the doctors love that champion this program. They feel like this isn't an extra shot or another pill. This is someone who will really walk through this with you. And so there's some great online shopping models for produce prescription, one called Attain Health that's out of Kansas City and serving many states, and they have a health coach model on their platform, and that's pretty much all you need. And then you've got it all fixed right there.
Love it. Mr. Last word? Ms. Teranova?
Just last word to emphasize the importance of trusted relationships. And so those community health centers and organizations like ours have that trusted advisor, the registered dietitian nutritionist, the other community members who really play such an important role in that coaching. Coaching is only as good as, people will listen to it.
Belief.
So.
I meant, that was in my mind to say at the very beginning as a framing element, but I appreciate that. You're exactly right. Mr. Chair?
Yep, thank you. And first, let me ask unanimous consent to enter into the record 7 statements outlining stakeholder food is medicine priorities without objection. So ordered. Recognize Senator Marshall.
Thank you, Mr. Chairman. I'll start with Mr. Williams. What obstacles exist that block us from harnessing personalized medicine today?
I think that building on the last point, when we look, at least from the entrepreneurial standpoint, the startups that we see, when you're a startup in this space, you have to make a decision whether you're going to be in the CMS lane or not.
Okay.
And if you're going to be in the CMS lane, then you got to comply with how it works. And there are things I know the entrepreneurs do that are not what they know is right for the patient, but is right because of the structure of how CMS works. It's not a criticism of CMS. It's really that they're there to deal with sick people, not proactive. So I think that that front end on CMS and also on FDA's standpoint in terms of what is nutrition, there are medical claims that we see in the new products that have more nutritional density that can't be made because when you go into FDA, it falls into a level of approvals that make it very difficult for an entrepreneur bringing new products to market to get through that buzzsaw. So I think both FDA and CMS and that front end, if we're expecting stuff to come from the innovators into this space, they need that pathway cleaned up a little bit or they got to go it alone and it's got to take longer.
Okay, all right. Ms. Martin, how would you handle the reimbursement part of this? What would you suggest that we should do to better reimburse for the food as medicine component?
The reimbursement should absolutely be integrated into the healthcare model. There are about 14 states that are either pending or have already passed 1115 waivers that are implemented into state Medicaid, and there's already Medicare and Medicare Advantage programs offering this as a reimbursable. I would think that it would need to be a pre-authorization for at least a year, and that would be paid up front to cover the food and the education.
Are you seeing it with any ACOs?
I have not.
Okay, all right. Dr. Mozaffarian, we got to talk about milk just for a second. You know, I'm kind of the champion of whole milk up here. Can you just speak a little bit? Have you done any research about whole milk, which, by the way, tastes better and the kids actually drink it, and we're going to have a whole new generation of boys and girls that develop osteopenia, osteoporosis at a much younger age. How do you feel about whole milk, and what does your research show?
Yeah, I mean, one of the reasons I got into nutrition was in the 90s when I was doing my medical training. It was the height of the low-fat diet recommendations. And when I read the science to educate myself as a doctor who wasn't receiving training on nutrition, the science in the 90s didn't support a low-fat diet. And so we were doing the best we could, but the science was, the policy was 10, 20 years behind the science. And so I knew right then that I had to really understand dietary fats. And so I've done a lot of research on dietary fats. And I think, although most Americans don't realize this, the dietary guidelines have quietly dropped the focus on low total fat. There is no longer a focus on low total fat in the dietary guidelines, which is appropriate. There's still a focus on low saturated fat, which I think is misguided and not actually supported by the evidence. And I hope the current dietary guidelines fixes that. But what that does is make recommendations for low-fat or non-fat dairy. And we've done research using observational studies, using biomarker studies, using meta-analysis, looking at a range of types of studies. And there's no evidence that low-fat or non-fat dairy is healthier than whole-fat dairy. There's some evidence that whole-fat dairy may be healthier than non-fat dairy, even the other way. And so from my perspective, we don't have enough evidence to only recommend low-fat or non-fat dairy. We should be telling people to eat what they choose, and we need more science. And I think the second point I would make is there's more interesting evidence about the type of dairy, and so fermented dairy, like yogurt with probiotics or cheese, which is actually the top fermented food consumed in the U.S., may be particularly healthful. And so I think we need more research on fermented dairy foods.
Yeah, and remind everybody that with the whole milk, you can absorb the fat-soluble vitamins A, D, E, and K. So it just makes sense to me, especially for my pregnant moms, to let them have whole milk. Go back to Mr. Williams. Talk a little bit more about regenerative crops and nutrient-dense food. What does that mean to you, and how do we get to them, and do they taste better?
Yeah, so you can imagine that just evolution says if something is more nutrient dense, you would want it to taste better, so you remember to eat it 200,000 years ago. So it is the case that taste and nutritional density tend to correlate with each other in crops. What we have found is that nutritional quality tends to come from the soil. So if you enhance the soil microbiome, you tend to have more nutrients available, the more nutrient uptake. Farmers are learning a lot better how to balance both synthetic fertilizer and the microbiome, and shifting into a mindset where regenerative is working. Further, what Erin has been seeing is that you can grow those crops in amongst existing agricultural products. So someone who's a 200,000 acre row crop farmer can also put 2 or 3 acres and work around regenerative. And then that supply chain is more local. It can be done 10 months out of the year, and then directly supply rural areas with more nutrient dense. But ultimately, that nutrition comes from the soil.
Yep. Well, Mr. Chairman, I just want to say again, thank you for letting us have this hearing. I'll kind of circle back to one of the statements you made that FDR was concerned about the malnutrition incidence in this country. I would postulate our incidence of malnutrition today is higher than it was in the 1940s. We have plenty of calories. That's not what I'm talking about. But the nutrition quality of our diet has deteriorated for a lot of reasons. I wish I could wave my hand and fix this. This is something I've worked on for 30 years and still struggle to find that perfect place. And congratulations to the folks that are finding success doing it, implementing. That's not easily done. So congratulations to you all. Thanks again to all of our participants today for your testimony.
Thank you, Senator, very much. And my father was actually a milkman.
There you go.
So the one thing we got was whole milk,
There you go.
butter, not margarine, ice cream. My wife is a physician, and she does say that one thing that my brothers and I don't have to worry about is osteoporosis. That we were definitely fed, with the preventative medicine, as children. And if I may, Dr. Mozaffarian, when I was a boy growing up with Tufts University a mile from my house, we had Jean Meyer writing a column in probably 200 newspapers every week on nutrition. He became the president of Tufts University. He died in 1993, but he was the world's leading nutritionist, and to a certain extent, that's why you're there, because of the legacy of Jean Meyer. Could you tell us, in the 30 years since Jean Meyer passed, what would he learn today that he didn't know back then in 1993? What has the research developed that the greatest nutritionist in the world didn't know?
Well, I'm the Jean Meyer professor at Tufts, and so it's quite a legacy and actually one of the reasons I actively try to bring science into action, which is what Jean Meyer's legacy was. He was not an armchair academic, right? He fought at the Battle of Dunkirk as a French infantryman and helped the British escape across the Channel, and then fought in the French underground and in North Africa. So I think what has changed since Jean Meyer passed is the unbelievable biologic complexity of how food affects our bodies. When Jean Meyer was in his prime and training as an excellent scientist, we thought about macronutrients and vitamins and kind of energy processing, and that's how a lot of Americans still think about food. They look at the back of the package and look at the calories and the vitamins. But food is more than vitamins and calories. Food is biologic information. Everything we eat is biologic information that affects almost every cell in our body. And so Jean Meyer would be amazed at how foods affect our gut microbiome, the fermentable fibers, the phytonutrients, the phenolics. He would be amazed at discoveries of things like epicatechin in apples, or oleocanthal in extra virgin olive oil, or EGCG in tea. These molecules that at nano microgram quantities have biologic effects. We've in the public literature, we've measured about 100,000 compounds in food, known compounds in food. There are startups like Brightseed that I advise in California that have now documented 2 million previously unknown compounds in plant foods and their biologic effects. And so I think Jean Meyer would be amazingly gratified and excited about this future where we really start to unpack all of these unbelievable biologic effects of food and how they can be our medicine and improve our health.
That is so great. And as a precursor to this hearing, back in 1986, I was able to include language in a bill with the support of Governor John Sununu, Republican of New Hampshire, and proud Tufts graduate, into the bill, which then helped Jean Meyer to build a new facility for research. So I think he'd be very gratified at the research that has now been conducted at the building, that he recommended be constructed, and that you are the Jean Meyer professor advancing his science and helping us all to understand much better the impact which food has upon all of us and how ultimately food can be and should be medicine for every person on this planet. So I thank Senator Marshall for recommending this hearing and his staff and all of our great witnesses for all of your very, very helpful testimony here today. And with that, this hearing is adjourned. Thank you.